Traditionally, simulated keratometry derived SIA is based on anterior corneal surface changes only, whereas the total corneal refractive estimate derived SIA is based on changes on the both anterior and posterior corneal curvature. Hence, there is a potential difference between the two methods of SIA calculation. Now, this is a prospective intervention cohort study, and the minimum sample size of 156 was based on the U1YCL study of 0.46 SIMK based SIA and 0.61 TCRA based SIA. The patient with the senile cataract with a regular examination was included in the study, and a 2.8 mm triplane clear corneal incision was constructed at the keratometric steep meridian. Now, all the estimating data at 3 mm was obtained on rotating stream flat pressure disc series tomographer, and it was divided into 3 groups of ATR, WTR, and oblique astigmatism. Now, this is the pre-operative astigmatism measurement differences were observed based on the SIMK and the refractive astigmatism. In this example, there is difference of 0.35 diopters in the magnitude and 28-degree difference in the angle in the axis. This is another example showing 0.5 diopter magnitude difference and 9-degree in the axis difference. This is another example showing 40-degree of axis difference. Now, those SIA were calculated and analyzed according to the Puller values method of this here, and this is the Excel sheet showing the calculations. Now, the demographic characters were comparable, and it was found that the pre-operative total corneal refractive astigmatism was significantly more than the simulated keratometry based astigmatism, 0.94 versus 0.74. And the SIA calculation showed that the refractive astigmatism based SIA was significantly more than the SIMK based SIA, 0.55, 0.39, and this was in all the subgroup. This was the ATR group. In the WTR group, it was 0.77 versus 0.55 and 0.63 versus 0.54 in cases oblique astigmatism. Now, this was true for the flattening effect also. It was 0.24 versus 0.15 in the ATR group, 0.47 versus 0.28 in the WR group, and 0.33 versus 0.26 in the oblique astigmatism group. Now, if we combine the results in the intergroup analysis, it was seen that the total SIA change and the flattening effect was significantly more in the WTR group compared, and it was minimum in the ATR group. Now, this was true both for the SIA based keratometry based astigmatism as well as the refractive based SIA. Now, if we get a combined result of ABC, that is WTR, ATR, and oblique astigmatism, it was find again the SIA in the refractive astigmatism derived SIA was significantly more than the keratometry derived SIA of 0.65 versus 0.52 for the total change SIA and 0.31 versus 0.28 for the flattening effect. Now, discussion. The high SIA is generally an undesirable element. It may prove useful in reducing significant preoperative corneal astigmatism. The maximum reduction in preoperative astigmatism can be achieved through on-axis incision or the preoperative steep meridian incision. The off-axis corneal incision will invariably create torque in different preoperative centers. Now, the similar results of to the present study was also observed by J. Liang, Yang YC, and Nuria Gorzan and Thomas Cohen for the combined results. And for the subgroup analysis, it was in comparison with the Young YCL study. Now, the explanation for the refractive astigmatism SIA more than the simulated keratometry SIA was that possibly due to the impact of the more central location of incision on the steeper posterior corneal curvature, there was a greater change is observed compared to the cut located more peripherally on the anterior cornea. The superior corneal incision WTR causes greater flattening of the posterior steeper meridian, reducing the ATR effect on the anterior corneal astigmatism, thus resulting in the higher SIA TCRA. And for the temporal corneal incision ATR, it causes increased vertical steepening of the posterior corneal surface, thus further adds to the ATR effect, increasing the refractive astigmatism SIA. Now, SIA is composed of two components, the flattening and torque. Burasita said that flattening is the parameter to which reduces astigmatism, and the torque is basically ineffective component of the SIA. It does not take part in the, it should not be input in the calculations. Now, the torque component was insignificant in the in all our groups, and this was in agreement with the study of the Chang, who also stated that the SIA calculation should be performed using ray tracing method of total corneal refractive astigmatism. The preoperative SIMK based astigmatism was significantly different compared to TSI, both in magnitude and angle, and this can have selection errors in toric implantation and steep meridian location and the calculation errors. The SI derived from the ray tracing TSI is significantly greater than the derived from the simulated keratometry. Hence, this calculation needs to be taken into consideration for planning the astigmatism correction with or without toric IL. The steep meridian corneal incision placement result in maximum flattening a significant torque component of the SIA. Preoperative less than 0.5 diopter WTR temporal incision may be employed, as otherwise the astigmatism axis will be flipped because of a higher magnitude of SIA. The on-axis incision can be particularly challenging to perform in superior nasal infection. Hence, it is recommended to make clear corneal temporal incision in such cases of less than 1 diopter, causing the least amount of astigmatism. The limitation lacuna, the superior nasal incision was not included. This increases the risk of deformity as a result of manipulation of the finger handpiece over the nose. The SI completion based on sclerometry steep meridian is based on this. Hence, the incisional flattening of SIA TRCA may not represent the actual post-operative outcome. The follow-up is of a shorter duration. Thank you. These are references.
Thank you, Dr. FAROOQUI. As always, one of the finest papers that he is always speaking on a lot of research and a lot of new development.